We are live.
A very good evening and warm welcome to iFocus Online Lecture 507 Ophthalmology Clinics Exam Special. Today we have none other than Dr. Ankur Singh presenting on the Grand Viva interpretation of retinal imaging and instrumentation. He completed his MBBS from HIMS Dehradun, Uttarakhand, and then MS Ophthalmology in GMC Patiala, Punjab. Finished his fellowship and senior residency in vitreoretina surgery and uveitis from PGI Chandigarh. He's also the holder of FRCS and FAICO vitreoretina. He's currently the associate professor at University College of Medical Sciences in New Delhi. He's been the assistant professor at All India Institute of Medical Sciences, Rai Bareli. He was the Secretary Teachers Association in UCMS. He's the executive member from the Delhi Ophthalmology Society. He's also an invited faculty at various international conferences and won several awards from prestigious state and national societies, including the Best Video Award, the APVRS Congress 2019 Award in China. He has multiple peer-reviewed publications in both national and international journals with various book chapters too. Editor and contributor to the renowned ophthalmology newsletters. We're proud to and honored to have you here, sir.
Thank you, Doctor, for such a lovely introduction. Yeah, can I share my screen now?
Yes, sir.
I think this should be visible, right?
Yes, sir. It's fine.
So, good evening, everyone. Today we are going to talk about the Great Viva interpretation of retinal imaging and instrumentation. So, what are the learning objectives that we are going to learn today? So, we are going to understand the principles of retinal imaging modalities, which I'm going to discuss, the key finding of these imaging modalities, correlate those key findings to come to a clinical diagnosis, and prepare ourselves for a Viva style question and MCQs. So, the things that we are going to discuss today are color fundus photograph, fundus autofluorescence, fluorescein angiography, ultra wide field imaging, optical coherence tomography, OCT angiography, and ultrasound B scan. So let's start from the first imaging device, that is color fundus photography. The principle behind is that it captures a true color image of the ocular fundus using the usual white illumination. They are mydriatic and non-mydriatic cameras. A single image acquired by these devices acquires around 30 to 50 degrees of the retinal field. And when you combine these 7 images as per the ETDRS protocol, you can visualize the 75-degree field of view of the retina. It's a non-invasive and quick modality. It is good for documenting retinal finding and as well as baseline screening. So for our understanding, I have divided the lesions in the retina as red lesions, yellow lesions, and white lesions. So red lesions can be hemorrhages. Hemorrhages can be dot and blot hemorrhages, flame-shaped hemorrhages. Then they have microaneurysms. How do you differentiate microaneurysms from the dot hemorrhages? Is that the size of those microaneurysms, the way they look. The size is usually around 20 to 100 microns, smaller than the dot hemorrhages, which is larger than the 100 micron size. So how do you differentiate this? So you look at the vein at the margin of the disc, and if you see that lesion is smaller, quite smaller than the hemorrhage is quite smaller than the size of the vein, then probably it's a microaneurysm. At the same time, it will have a very well-defined structure, as well as it will be slightly refractile. It will be purely red, while a hemorrhage would have a deeper red look to it. At the same time, you can also see some abnormal red tissue or abnormal red appearance in the fundus, which could be a vascular abnormality like an NVE. Yellow lesions are basically drugens, hard exudates, and choroiditis patches. Again, drugens can be small, intermediate, and large. Again, that would depend on the size of the drugens. Drugens are at the level of the RPE, so they are going to look subtle yellow, while hard exudates are in the outer plexiform layer. So because they are up, so they're going to look more brighter yellow. Size will again be quantified with the venous size, and you will be able to differentiate them by the look and the refractile property of these individual identity. Sometimes you see those choroiditis patches, and this choroiditis patches, because they are having the choroid hue as well as coming from the deep of the retina, they're going to appear yellow. So what you see in this image here is a choroiditis patch, and this is looking yellow. Then there are white lesions. White lesions can be a cotton wool spot, a myelinated nerve fiber, retinitis patch. So cotton wool spots, how do you differentiate cotton wool spots or myelinated nerve fiber, which are both affecting retinal nerve fiber layer? One, retinal nerve fiber layer, when gets myelinated, it is going to be over the vessels also. But usually the cotton wool spots spare the vessels. So if you see those small limited whitish areas, probably you're looking at a cotton wool spot. When you see those those whitish regions across, which are large span, have those projections of the RNFL, probably you're looking at a myelinated nerve fiber. At the same time, when you see those whitish, dirty white lesion associated with hemorrhages, probably you're looking at a retinitis. These are just the way these lesions are described. There would be other signs and symptoms apart from these, the color itself, to help you to identify the lesion, which I'm going to discuss further. So, how do you differentiate? How do you use these knowledge that you have acquired about these lesions to understand a disease? So if you see multiple dot and blot hemorrhages with hard exudates which are spread over the posterior pole, you're probably looking at a patient of diabetic retinopathy. When there are more of cotton wool spots, less of that dot and blot hemorrhages, few more flame-shaped hemorrhages, probably you're looking at a patient of hypertensive retinopathy. And if you see those angry-looking hemorrhages spreading across the disc all the way to the periphery, which can be quadrantic or it could be 360 degrees, all the quadrants, probably you're looking at a patient of a BRVO or a CRVO, that is vascular occlusion. Again, we have discussed drusen, and drusen can do form the part of dry RMD, which can be early, intermediate, advanced. At the same time, when you look at the macula, and if you see the breach in the breach in the retinal layers, and you see this reddish hue in the center of the around the fovea with perivascular cuffing, hole cuffing with yellowish hue, probably you're looking at a macular hole. Sometimes your patient comes with a whitish reflex. You get this patient undergo a fundus photography, and you see this, whitish appearance. Probably this is nothing but a retinal detachment. And you can also visualize that this is the line where you can demarcate where the site is retina is attached as well as where it is detached. So retinal detachment can be fractional. Again, fractional can happen in periphery or at the posterior pole. So posterior pole usually associated with diabetic retinopathy. So the patient would have vitreous hemorrhages and other features of diabetic retinopathy. When it is associated with sickle cell retinopathy, then it is going to be more peripheral. Then you have to also understand these retinal detachment can be exudative. Exudative will have those Darmstadt effect, shifting fluid that we can, you have to read about it, but then this is how it looks. Then you can also, if this detachment can be associated with a tumor which is below it, which is giving it an endophytic appearance, and you will see those beautiful retinal vessel crossing over that tumor. Apart from the retina, fundus photograph can also help you to assess the amount of edema, the optic nerve edema the patient have, so that in the due course of time, when the patient this edema resolves with the treatment, you can assess the resolution by clearing up the margins of this optic nerve. At the same time, you can follow up these patients by taking those imaging these patients for glucomatous optic atrophy. So one thing is commonly asked in exam is, what is the other way to take a fundus image? That's a red-free image, and which cases do you prefer to do it? So these are the patients which will have hemorrhages. So hemorrhages are better seen in red-free images. At the same time, RNFL is also better seen on red-free images. So how far we understand with the color fundus photography is that it's the first line modality for variety of retinal condition, but it has a relatively limited field. So now for that, we need to grow up to, or we need to explore ultra wide field. It has inability, it doesn't allow us to visualize the subtle RP changes. So for that, we need fundus autofluorescence. It has inability to visualize the dynamic changes, how the blood is flowing. It cannot see that. So for that, we need FFA and ICG. So that brings to the second imaging device, that is imaging modality, that is fundus autofluorescence. It uses a short wavelength excitation light, which is usually blue in color. What it does is it excites the lipofuscin and other fluorophores in RPE, which emits the yellow-green light. And then there is a barrier filter which removes the any other light except the yellow-green light, and this is seen as a fluorescence. So you can see these patients with autofluorescence as brighter area, which is suggestive of increased lipofuscin density, and the darker areas which are decreased lipofuscin density. So what you see here is a patient of BEST. And you see this has an increased, refractile, hyperautofluorescence. So this means that this is something to relate with lipofuscin. However, this is a normal patient over here. What you see is that this is bright, but this is less bright. So why it is so? Because there is xanthophyll present over the around the fovea, which absorbs the this refractile nature of the autofluorescence. So this is darker. So one place where you will not find any lipofuscin is at the disc. So disc is absolutely dark. Other places where you will not see any lipofuscin is where there is an RPE atrophy, because it is a metabolic map of the RPE. So any patient with geographic atrophy, you will see this hypoautofluorescence or darker areas. But look at these small areas of hyperautofluorescence. So what this means is that there is this disease is progressing, this geographic atrophy is progressing. So this hyperautofluorescence is going to tell you that this is a progressive lesion. Something is happening at the very margin of this disease. So as you have described, again, looking at this image over here, you can come to know. You always have to compare it with the color fundus photograph. But you do a color fundus photograph, we do a fundus autofluorescence. You look at this image, which is, this is the geographic atrophy. With the enlargement of the geographic atrophy, this is going to happen in, due course of time. Then this patient is of basically dry AMD. Another patient which I already discussed is a patient of, Best vitelliform dystrophy. Look at this. This area is, hypoautofluorescence. And you see this, hyperautofluorescence ring. So this is usually described in book as a circular ring, which is Robson-Holm ring, and this is the area where the retina is still functional. And the rest of the part, you have those bony corpuscular appearance. Probably you're looking at a patient of retinitis pigmentosa. Another disease in the degeneration dystrophy armamentarium is the Stargardt disease, and Stargardt disease affects ABCA4 gene, which leads to increased production of lipofuscin. So again, increased lipofuscin, you will see these speckled hyperautofluorescent spots suggestive of Stargardt disease with central geographic atrophy. So, Gupta et al., Amod Gupta sir and Bansal et al. Described how does lesion behave of the serpiginous choroiditis on autofluorescence. Can we treat those patients based on the autofluorescence? Yes. So initially, when you have a lesion which is inactive, this is going to have a fuzzy margin and a hyperautofluorescence. As the lesions start healing, in due course of time, it will have a speckled kind of appearance as you see over here. And once the lesion is healed, it will be having a hypoautofluorescence. So when you achieve this in this place, this means the patient or the treatment can be stopped because the lesion has healed. So I would summarize that what autofluorescence does is it detects subtle RP alteration before they are visible to the naked eye or even the fundus photograph. In patients like central serous retinopathy, you are confused the patient is a chronic case or acute case. If the history doesn't goes in favor with you, do an autofluorescence. You see those gravitational hyperautofluorescence tract and hypoautofluorescence and hyperautofluorescence tract. Probably this is a patient of chronic CSC. So it's a non-invasive metabolic map of RP. Now we are going to go to another imaging modality, that is fundus fluorescein angiography. It's an invasive dynamic assessment of the ocular vasculature. You can use 10 ml of 5% fluorescein, or 5 ml of 10% fluorescein, or 3 ml of 25 or 20%, because in our country, the most commonly available is 20%. You can use 3 ml of 20% fluorescein solution. So when the fluorescein dye, the sodium fluorescein dye enters into the blood, and you excited with the blue light, it emits fluorescence. So images are taken with from the same fundus camera, but it has to have a barrier filter to prevent any other light to come back the blue light to come back to the camera. So if you don't use that filter, you are not switched on the filter, then probably you will get a blue image. Once you switch it on, you will get the fluorescent image or the fundus fluorescein angiography image. So these images are taken at a particular time duration, and these time durations can be divided on the phases of the fundus fluorescein angiography. Namely, these phases are choroidal, which is 12 to 14 seconds after you have injected the dye, which is known as arm to choroid time. 1 to 3 seconds later, the choroidal flush is the arterial phase, which lasts for 1 to 2 seconds. Then from after that comes the atriovenous phase, when this fluorescein moves from the atria through the choriocapillaries to the vein, and it has a laminar flow, and that duration is 20 to 25 seconds. Then there's a venous phase in which the dye has entered into the veins of the eye, and this is the time you get the brightest contrast. So if you want to look at the CNP areas compared to the perfused area, this is the time you should choose, because this gives you the most contrast in the retinal structures. Then is the recirculation phase, where the dye washes out and it goes back to the general circulation. So understanding of the fundus fluorescein angiography is hyperfluorescence. Hyperfluorescence before the dye injected is autofluorescence, that can be seen in optic nerve adhesions. If you see the abnormal vessels which are seen over the retina in the choroidal phase, probably you are visualizing the choroidal vessels through a window defect. A window defect is present in the RPE. RPE masks the choroidal flush to directly to reach to the camera. So if you have an RPE defect, a geographic atrophy, you will see a window defect as early as at the choroidal flush phase. So when the dye leaks, it doesn't increase in size, is called as pooling. When there is an increase in intensity, like in a scar, where there is increase in intensity of the reflectance, but the size doesn't increase, is what is staining. And when the dye increases in size as well as it increases in the property of reflectance or the property of fluorescence, then it is leakage. So how does it, and then what is hyperfluorescence? Hyperfluorescence can happen because of the filling defect or the block fluorescence. So when you are not able to see the vasculature of the retina, the choriocapillaries, and you see this as, this grayish appearance, probably this all is a filling defect. But how do you differentiate it from the area which is having, block fluorescence? So you always compare the fundus fluorescein angiography with a patient with the color fundus picture. And if you see this as an hemorrhage, probably you are looking at a block fluorescence. So how does these fundus fluorescein angiography help you to identify a disease? So if you look at the CNP areas, then you see those multiple microaneurysms, NVEs, disc NVD, because this is going to leak in the late phase. Then probably you are looking at a diabetic retinopathy patient. Why it is important to do a fundus fluorescein angiography? Because this is going to tell you about the macular perfusion status. And in this image, what you see is that the macula is not perfused. There is an enlargement of the foveal avascular zone, and this patient is not going to do well with any kind of anti-VEGF, because the macula is in fact not perfused. At the same time, you can see this as a leakage. The filling defect has been discussed over here, leakage from these microaneurysms, which in the late phase is going to develop the CSME. So this will leak more in the late phase, and this area will be all covered with the leaked dye, which is going to help you to confirm the diagnosis of CSME. You do see an abnormal vessels over here, which are taking up the abnormal dye, which leaks in the late phase, telling you that this is nothing but an NVD, and probably this is a diabetic retinopathy patient. So again, if you see a patient which has a large CNP areas, capillary non-perfusion areas, which is like this, and then you see this staining, staining of these vessels. So this staining usually depicts that there is some kind of decrease in the flow. So this is associated with increased arm to retina time. The dye doesn't come to the eye that early; it's coming very late, and then probably this patient might be having a patient of CRAO. At the same time, when you see those tortuous vessels, which is not here, but then you see those tortuous vessels with again the CNP areas over here, with it might be associated with an NVE or might not be. Probably this is a patient of a vascular occlusion. So a vascular occlusion, the dye will come into the eye at the right time, but then this will show you as a CNP area. At the same time, if this patient comes late, you will see these collaterals. So this was supposedly the CNP area before, but now the collaterals have formed at this place, and this is how these patients of BRVO behave over time. Again, you see this petalloid pattern which has been described in fluorescein angiography, and this usually happens in the late phase. So if you see those petalloid patterns, which you can see over here, which is in the late phase, so probably you're looking at a patient of CME. But you see, staining at or the abnormal vessel at very early phase in the choroidal flush, which leaks profusely in the late phase. Probably you're looking at an CNVM, and a classical kind of CNVM. If this would not have been a classical, this would have shown stippled hyperfluorescence. Again, when you see the hyperfluorescence associated, this patient might have vitreous cells, might not have vitreous cells, and you do a fluorescein angiography in this patient, and you see that there is a leakage of dye along this vessel wall with these perivascular infiltrates. Then probably you're looking at a patient of vasculitis. And again, and this is a image which is taken in an early phase, and you are seeing those filling defects. You're seeing these filling defects. So these filling defects are because of the granulomas that they are in the choroid, and which leak profusely in the late phase with disc hyperfluorescence. So this is a hot disc leaking, these pulling of the dye into this neurosensory detachment. And then you will have to do an OCT in this patient. But this tells you probably you're looking at a patient of a BKH, which goes from hypo to hyper with disc hyperfluorescence. So to summarize, FA is a dynamic test. It is contrast enhanced. It gives you a contrast enhanced view of retinal and choroidal circulation. It highlights the area of vascular perfusion, leakage, blockage, and abnormal anastomosis. It is a baseline diagnostic test to be done in an unexplained visual loss where you're thinking of vascular pathology. It can be even a patient of AION. So you can do an fundus fluorescein angiography, and you can see the filling defect with the optic disc, or in a patient of macular ischemia, in a patient of RVO. So it tells you about the vascular perfusion of the disc as well as the retina. It is useful to guiding us the site for treatment. You look at those CNP area, treat them with the scatter laser, and probably you can also plan or defer anti-VEGF. So again, FA is an invasive test. It carries small risk of adverse reaction, which could be minimal, usually nausea. But sometimes the patient can have more dangerous anaphylaxis reaction. So now we come to the next imaging modality, which is ultra wide field imaging. So what it does is it is a confocal scanning laser technologies with wide angle optics or an ellipsoidal mirror, allowing to map the curved retina effectively using that wide angle optics or the ellipsoid mirror. Because now this is converting the 3D data that it has acquired, because the retina is curved, the eyeball is curved, into the 2D map. There's some peripheral distortion. However, the devices that the wide angle devices that we have now improve this peripheral distortion, and you can see these images beautifully. So what PG should know that it captures 200 degrees of the retina, which covers 82% of the retina. And when you combine the two ultra wide field images, you can even get 220 degrees of the retinal field. It is a best device to document peripheral retinal lesions with high resolution. An international wide field imaging study has defined wide field as 100 degrees and ultra wide field beyond 100 degrees to 110 to 200 degrees, reaching to the ora cellular. So this is an Optos fundus photograph of a patient who came with an RD, and then this patient underwent a buckle. So what you can see the buckle effect over here. You can see the buckle effect over here. At the same time, you can see the margins of the, the break. So the break, you can see these cryo marks, and this break is fine. It is not pruning up. It is not opening up. So you make this patient sit on an Optos. You take an image, and you know that the patient is doing well. At the same time, this is one utility of this device. At the same time, this is an image that you get with the normal fundus camera. Again, this patient undergoes an Optos image view for the fundus, and you find these lesions, these hemorrhages in the periphery. Apart from this, you also see how inadequate this PRP is. This is all the PRP that is done. And the same patient undergoes a fundus fluorescein angiography, you find that this is the amount of the CNP area that this patient has. So this just not only tells you that this patient has inadequate laser, but you also come to know the reason for this NVE is this large amount of CNP area. So what did the study tell us? The study told us that there are predominantly peripheral lesions, where the 50% of lesions are there in the periphery. The diabetic retinopathy is seen in 37 to 50% of the eyes, and presence of these predominantly peripheral region increases 4.7% risk of these patients developing PDR. So if you have an fundus, if you have an ultra wide field angiography or ultra wide field camera, you can identify these lesions which are there in 50% of the patients and treat them timely. At the same time, the diseases which affect the retinal periphery, for example, acute retinal necrosis. So you can quantify, you can visualize, you can quantify, you can treat, you can see the scar forming. In fact, you can even see any break that is going to happen in that scar tissue by doing an ultra wide field image. So what it does is it provides more comprehensive retinal evaluation. So more the information, better can be the management. In a pediatric and a non-cooperative patient where it's difficult to do, an IO in direct ophthalmoscopy, or in fact, it's difficult for the patient to sit there to get those 70 ATRS images, patient to look in the different directions. You do a single shoot capture with those ultra wide field cameras, you're done. Then if a device which covers 82% of the retina information, this can be used to transfer to the concerned person and can be a very good armamentarium for telemedicine. But then just like any modality, it has some problems that it produces pseudocolor. The devices that use scanning confocal laser, they produce pseudocolor, and then there are artifacts because of the eyelashes. But this can distort your evaluation. But with time we tend to develop upon that how these pathology look in these 3 colors images or 2 colors images. But residents needs to remember that it does not replace it with clinical examination. So although the patient has undergone an ultra wide field imaging, you still need to do a good clinical examination of this patient. So now this brings me to the next very important imaging modality is optical coherence tomography. The optical coherence tomography uses near infrared light, and the principle that is utilized to do an OCT is low coherence interferometry. In simple language, it is that it has 2 beams. So one is a reference beam, which goes to the reference mirror, and the other beam, which is reflecting from the retina. An interference pattern between these 2 beams creates a cross-sectional image of the tissue. So from this is a non-invasive, high-resolution cross-sectional imaging of the retina. Probably it is good to say it's an optical biopsy, non-histopathological optical biopsy of the retina. So from the time domain, from the era of time domain OCT, we have gone to Swepsov's OCT. And what has happened is the wavelength has increased, so the penetration has increased. So now we are able to look at the choroidal, not just the choroid, but the choroid scleral interface. And at the same time, the axial resolution has also improved. So Swepsov OCT usually has an axial resolution of around 3 microns. So the axial resolution tells us that how well it can differentiate the retinal structures, the retinal layers. So international nomenclature of the optical coherence tomography told us that not just the 10 layers of the retina. Now we should know that there are 18 layers of the OCT Blaze, 18 layers of the OCT Blaze classification, in which they have revised this ellipsoid zone. This was previously known as ISOS junction. This came in 2014 by international nomenclature of optical coherence tomography. So we will go from the interface, the vitreous interface, all the way down to the choroid. So what are the pathologies which affect the vitreous interface? So if you see these multiple dot things which are hyper reflective, but you see normal retina, probably these are nothing but asteroid halosis. But if you see an altered retina, like this is an hyper reflective in which the layered structure of the retina is damaged with these multiple, hyperreflective dots in the vitreous. Probably this is a patient of having some kind of retinal inflammation with vitritis. Then you can also visualize the vitreoretinal interface, how this PVD is happening, the various stage of PVD, the hyperreflective PVD with the hyperreflective preretinal space, and the various stages of PVD formation. So, International Vitreomacular Traction Study classification, we need to know what is a vitreomacular adhesion. Is it focal? Is it broad? So what you see over here is a broad VMA. When this causes traction, you see the distortion of the fovea. This is a vitreomacular traction, and this eventually leads to this can eventually lead to macular hole, or can just go away with simple PVD. So then there are stages which has been defined by Gauss as 4 stages of 1A and 1B, 2, 3, 4 stages of macular hole. So what you see over here is the stage 1 macular hole, the partial operculum stage 2 macular hole. The operculum has gone up, so now this is the stage 4 macular hole, and this has to be larger than 400 micron. So now we have a closed classification, which talks about the macular hole which is larger than 400 micron. So this classification not only gives a nomenclature to these holes, but how these patients are going to behave with various approaches of treating these macular hole. Apart from this, the resident should know what are the different macular hole indices. One of the important are macular hole index and hole forming index. So if you can take the photograph of this image, this is how the measurements are done, and this is how these indices are calculated. So macular hole can be treated, and they will undergo type of closure. They can be a type 1 closure, which is over here. This is type 1 closure, and it can be type 2 closure, which is unclosed hole. So type 1 closure can be a U-shaped closure, V-shaped closure, W-shaped closure, or an unclosed hole. So what do you see in this patient? You see this looks like a macular hole, but then this is not a full thickness defect. So this is a pseudo hole, because this is the culprit over here. The contractile property of the ERM has dragged the retina closer, making this give an appearance of a pseudo hole. So when you see this dumbbell shaped opening in the retina, which is not full thickness, it's a lamellar hole, and it can also have a head shape, which has been classically described. And this usually happens because in this patient, what has happened, these cystic spaces are deroofed. So deroofing of the cystic spaces can lead to development of the lamellar holes. And the classic picture I have already discussed is an inverse head side. So now you also have to talk about contour. So contour is abnormal over here, and the culprit is the presence of ERM. The ERM has dragged and changed the contour. Then there is an identity known as foveal ectasia, where the foveal contour is either absent or minimal. Then you need to know about another identity which is known as taut posterior hyaloid membrane. This is an identity which is seen associated with diabetic retinopathy, and what you see is an hyaloid which is hyperreflective, tight, and this is what is leading to this persistent traction on the fovea. And in this case, it does again lead to deroofing of the cystic retinal, the cystic spaces of the diabetic macular edema. Now let's talk about the structure of the retina with the help of an OCT. So in this, you see those typical well-described cystic spaces, but you don't see any hard exudates over here. You don't see any abnormality which is associated with diabetic retinopathy like drill. So you see layered retinal structures with these cystic spaces, then probably you're looking at a patient of cystoid macular edema. You see some hard exudates like this over here with these cystic spaces, this neurosensory detachment, and the patient will have certain signs of diabetic retinopathy on the fundus picture. Probably this is a patient of diabetic macular edema. Look at this image. You see this side has increased thickness than this side. And then you see these cystic spaces over here. And this layer is having more reflectivity. So for your understanding, what this patient has is the edema of this layer with some vascular pathology leading to hyperreflectance and those cystic spaces. So something which is affecting half of the retina, hyperreflective edematous. Probably this is nothing but a case patient of a RV-associated macular edema. So now look at this image. You see those pillar-like cystic spaces. Are the cystic spaces or there's something else? Then you see this ERM. What are these? And they are running all across. So it's like retina is split. So when the retina is split, and what you see, these are the molar pillars. So you are looking at the retinous cases, and in this case, it's the retinous cases with ERM interaction. So neurosensory attachments, the OCT can be localized or could be global. So if it is global, and how do you know it is global? Because here we are not able to, if this is a 12 mm scan, and you're not able to look at this part that this retina is attached, then this is a global detachment. So global detachment probably is a retinal detachment. So you might say this is CSR in exam. No, this is not CSR. If you see this detachment which is there, so probably this is a patient of an RD. Again, if it is a local detachment, as you see over here, with an hyporeflective foci with a PED, because this is the RP-Brooks membrane complex. This is RP-Brooks membrane complex and splitting of that. So this is a PED. This is an hyperreflective space below the retina, and this is localized detachment of the fovea. So this is a patient of CSR, because you see those elongated photoreceptor cells. Then this is a chronic CSCR. Then you see this hyperreflective area. Then this is probably the site of the break in the RP, which is leading to CSR formation. So this is a chronic case of CSR, and this assessment has been solely done based on the OCT. Then there are other those hyperreflective spaces in the retina. You see one hyperreflective spaces over here, one in the outer retina, and one going all the way up to the inner retina. Are these cystic spaces? No, they don't look like cysts. So these are cavitated lesions, and these cavitated lesions are well described in pathology known as macular telangiectasia type 2. And what you see here is nothing but the ILM. So this is being described as a drape sign. Drape is curtain. So if you see the ILM lying over these cavity spaces, just like curtain, probably you're looking at a patient of McTell type 2 patient. So sometimes you see these defects in the photoreceptor layers, and the patient gives a history of exposure to the eclipse. Then probably this is nothing but a soral retinopathy. So that's not it, because with the help of these newer generation OCTs, we can look at the the choroid. We can look at the choreo scleral interface. So do you see the subtle elevation, and with these subtle elevation are somewhere around below the RP, but they do not cast any shadow. So probably this is nothing but retrusion. When you see again the splitting, but associated with cystic spaces, then you are looking at a type 1 CMA, because it is below, it has not breached into the retinal cavity. It has not breached into the retinal layers. So this is a type 1 CMA. Look at this. You see this, some kind of whitish lesion with this kind of deposits. I have discussed this before. So this is again the same lesion which was hyperautofluorescence. And these are lipofuscin deposits. So probably looking at this image, you are looking at a patient of Best vitelliform dystrophy. So now with the Swepsos OCT and the EDI OCT, we can look at the choroid. So choroid thickness is very important. So localized thickening of the choroid, as you see over here, with loss of the outer photoreceptor segment, with edema over here. So probably this is a choroidal granuloma, and this choroidal granuloma is causing inflammation of the outer retina and leading to these changes. Again, there is something known as pachychoroid. For pachychoroid, you need to understand it is just not the increased thickness of the choroid. It is associated with choriocapillaries atrophy. So the inner layer is atrophy. You see those large vessels going all up to the RP-Brooks membrane complex. Probably this is a patient of a pachychoroid. So OCT is a non-invasive. It provides you an optical biopsy. It helps you to visualize individual retinal layer and to assess the pathology affecting individual retinal layers. Why it is important? Because there are certain entity which has been described on OCT which are not affecting all the layers of retina. One such entity is paracentral acute middle maculopathy, PAM, which is a vasculopathy affecting the middle layers of the retina, described by Shroff et al. So that diagnosis came because when we had OCT. If we didn't have OCT, we couldn't have diagnosed that entity. It is a very good monitoring and treatment decisive tool in a patient of AMD or a DME. It can help you to when to give anti-VEGF, when not to give anti-VEGF. Is there increase in the amount of the fluid associated with decreasing the visual acuity? At the same time, it tells you, is it center involving or non-center involving kind of macular edema, helping you to decide whether to inject or think about laser to an FFE. So it's an optical tool, and like any optical tool, it is affected by media clarity. It does not provide the information about the functional status. The functional status information is provided by the autofluorescence. But morphological imaging often mimics the functional change. So you can call it as a quasi-functional tool rather than calling it a non-functional tool. So that brings me to another development to the OCT, and that is OCT angiography. And the motion contrast processing of these OCT images is what is OCTA. OCTA is a dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormality. It provides us with how it works is that it takes sequential rapid B scans at the same retinal location, and what it detects is the decorrelational signal which is set up by the traveling of the RBCs. And these RBC which has traveled and led to this decorrelational signal makes the machine understand these are the vessels. So this 3D volumetric data that has been acquired by the machine is presented as a form of ENFAS images, that is 2D representation of the 3D volumetric data. And these are the ENFAS images. So ENFAS images, it provides you with a cross-sectional as well as ENFAS images. ENFAS images are superficial retinal capillary plexus. The ENFAS at the intermediate retinal plexus, the ENFAS at the deep retinal capillary plexus, and ENFAS at the choriocapillaries. The newer machines, you can have ENFAS at various predefined levels, but these are the common ENFASes. So as a resident, you need to know there are quantifiable variables in OCTA, which is foveal avascular zone. This is the area of the phage. Then ascircularity index. Ascircularity means how much your fovea differs from a perfect circle. So if the value goes down, this means this phage is getting acircular. So this means there is a development of the enlargement of the foveal avascular zone, and this development of PDR or the development of macular ischemia in this patient. You can also get vessel density, that is total length per unit area. Foveal density 300 is vessel density in a 300 micron area around the foveal avascular zone, and there is perfluence intensity. So these are pre-built, quantifiable variable. And why these are important? Because these quantifiable variables can act as a biomarker. So decrease in these values in different diseases can help you assess the progression of a disease. So I'm just going to I'm not going to discuss those details. I'm just going to discuss the morphological assessment of OCT angiography over here. So OCT angiography can help you to differentiate and detect neovascularization. So if you see those abnormal vessels in the vitreous plane of vitreous phase of the retina, because new vessels have a tendency to rise above the level of the retina, and you see this abnormal flow in the vitreous as described by the Bailey et al., then probably you're looking at a patient of an NVD with the help of OCT angio. OCT angio can also differentiate between collaterals and NVD. Based on the morphology, collaterals are mirroring vessels. They do not rise into the vitreous plane. They are best visualized in the radial peripapillary plane. And this is our study, in which we were able to differentiate almost all the patients between collaterals and neovascularization in a masked way between two groups of an RVO and an diabetic retinopathy. So not just that, you can OCT angiography can remarkably quantify CNP area. So when you look at this image, you don't see any CNP area. But you do an OCT angio of this patient, you see that these are the CNP areas. So CNP areas which are not able to visualize because of the leak of the dye are better visualized in OCT angiography. So this is an NVE and the CNP area. However, OCT angiography can visualize microaneurysm as you see over here, but when you compare it with FFA, the detection rate is only 54 to 77.6%. So when your question is asked to you that is it OCT angiography a very good tool to detect microaneurysms? Comparably, not that good. For other pathologies like macular status, ARMD, CNVM, it's a good tool. So with the help of OCT angiography, you can also visualize these this neovascularization elsewhere. And again, as I've described you before in the FA, if you see those CNP areas with neovascularization elsewhere, this is nothing but a patient or retinal venous occlusion. And if you do, and what you see is this abnormal flow. So reduction in the size of this abnormal bunch of vessels with reduced flow can help you to understand that you have done a scatter laser, the patient is responding well. As I've described before, OCT angiography takes depth-based and fast, so it can detect pathology which are affecting a particular layer of the retina, as seen in this sickle cell maculopathy patient, where the deep capillary plexus is affected, sparing the superior one. So on FA, you will not be able to see this CNP areas or flawoid areas because this part will have dye, part will not be visualized. But then on an OCT angiography, you can clearly delineate the CNP areas in the deeper capillary plexus because of the depth-based imaging of OCT. So in plain simple language, OCT can assess flow void areas or abnormal flow in the various layers of the retina. As you see over here, this entity has been described as Raff et al., which is acute paracentral acute middle maculopathy, where the blood flow is affected in the deep capillary plexus or the middle layers of the retina. So this will have a good flow, this will have a good flow, but this will have affected flow. So within OCT, you can clearly visualize this flow void areas, but on FA, it would be difficult. So OCT angiography can not only visualize the CNP, visualize the abnormal vessel, it can delineate the different kind of CNVM, because again, as I have discussed before, you can take the scans at different various depths. So it can tell you, is it type 1 CNVM, type 2 CNVM, type 3 CNVM. It can also visualize non-exudative kind of CNVM. So although there is no cystic spaces, no leak on the FA, but you can see a non-exudative kind, which is not exudating yet, of CNVM with the help of Octave. And why it is important to know? Because these are the patients which are going to progress to develop a full-fledged CNVM in time. And this is what, in some time, because this is what the studies have told us. Then if you see these abnormal vessels spanning from the superficial, intermediate, and deep retinal capillary plexus with abnormal flow, probably you're looking at a RAPIs. At the same time, OCT angiography can also help you to assess choroidal abnormalities. Like you see these flow void areas in a patient of VKH, and when you start treating this patient, these flow void areas reduce. So these flow void area reduction is correlating with the healing of these granulomas. So although the neurosensory detachment would have settled, but these flow void area might persist. So OCT angiography in these patients help you to understand the reduction in these flow void area, and after that complete absence of these flow void areas can help you to guide that this is the time when you can stop the treatment. OCT angiography can also be used in various white dot syndrome. In certain cases, it has been seen that multiple evanescent white dot syndrome do not produce any flow void area in choriocapillaries, while the other kind of like APMP kind of APMP kind of the APMPE kind of white lesion produce those flow void areas in choriocapillaries plane. So this can help you to do it. If a patient comes to you with a white dot lesions, you make this patient sit on an OCT angiography machine. You can differentiate whether this patient is having multiple evanescent white dot syndrome or an APMPE, just based on the scan, on the choriocapillary scan. But the recent reports have also shown that with the development of higher swept source OCT, which I take faster scan, we are able to see flow void areas even in multiple evanescent white dot syndrome, which equates with what is seen on ICG. So with the availability of wide field octa, that is 14 by 14 scan, you can also detect those abnormal entities like idiopathic retinal vasculitis or IRWAN, retinitis or IRWAN diseases. So I would like to summarize is that it's a non-invasive, dye-free assessment of the retina and choroidal vasculature. Artifacts can alter findings and media clarity is requirement in octa. So always correlate the emphasis OCT with the structural OCT, because sometimes what you see might not be a pathology. I've not shown an image over here because short of time. But if sometimes what you see as a cystic space is not a cystic space, or what you see as a phlovoid area is not a phlovoid area, but just a cystic space. So if you look at a phlovoid area, you correlate with the structural OCT, probably you're looking at a cystic space rather than a true phlovoid area. So adjust segmentation manually because it is required. Sometimes, erroneous segmentations in an OCT angiography can give you a false impression of a CNV. With the diet scanning protocol, when you're looking at the fovea, use 3 by 3 mm protocol. When you're looking at a larger area like diabetic or an RVO, take a montage or a larger scan protocol, which is 12 by 12 mm of the newer machines. Knowing anatomy is very important because that is going to, because you can only assess the retina unless you know the anatomy. You will not know what to look for if you don't know the anatomy. And now in 2025, there was a publication which has come about the standardized OCT angiography nomenclature. So the nomenclature which was not standardized before is getting standardized. Now that brings me to the last modality of today's class, that is ultrasound B scan. So ultrasound B scan is a brightness scan. It is a 2D scan mode made up of an array of A scans based on pulse echo technique and tissue acoustic impedance mismatch. So greater is the acoustic impedance difference, or the greater is the reflectivity between the two adjacent layers of the sound, is the brighter will be the tissue. The probe that we use usually for doing an ultrasound B scan in our hospital is 10 to 12 megahertz. And you should always try to read those B scans along with the A scan. So as I've, the larger is the acoustic impedance difference between the two layers. So it will be brighter, as can be seen retina sclera, as well as clotted blood and calcification. And lesser is the acoustic impedance, it will be seen as black or fluid. So this difference from here and here is higher acoustic impedance. That is why you see the retina as white. So indications of B scan are when there's an opaque ocular media, when you want to look at the tumor in a clear ocular media, and then when you are able to visualize the intraocular foreign body. I'm not going into the details of indication because of the lack of time. So the ultrasound B scan can be done with the direct application of the probe to the ocular surface over the lid, as well as the immersion technique. The most important thing to understand is which scan to choose and what is a scan type. So there are axial scan. Axial scans are when the probe is placed center to the cornea, and the position and relation to the of the lens and optic nerve is assessed by an axial scan. It gives you an axial length, as well as it gives you a rough assessment of the macular pathology. Then there are longitudinal scan. Longitudinal scan is a scan where you can measure the pathology from this to the periphery, and then there's a transfer scan. Transfer scan is when you are placing the probe parallel to the limbus. So when it is perpendicular to the limbus, it is a longitudinal scan. When it is parallel to the limbus, it is a transfer scan. And with the help of the transfer scan, the 4 transfer scan here, 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 and here, you can measure 94% of the eye. And if you make this oblique like this, the rest 6% can also be assessed. So sorry, measured is not the right word. It can be assessed. So looking for a lesion, you want to assess the complete part of the retina, you do a 4 transfer scan along with making them oblique. Then the rest 6% part is also taken care of. So the important thing in B scan ultrasonography is how do you describe them, these lesions. So you describe them on the topographic criteria, the quantitative criteria, and the kinetic criteria. So we'll understand. So topographic is the location. The location can be is usually depicted as glaucous or relation to the disc. The shape, is it round, pear shape, flat, or collar button type? The size and the borders. The structure, is it regular or homogeneous, or is it heterogeneous? And then there is reflectivity and sonic absorption. So is it highly reflectile, or does it have a high sonic absorption? That's what I'm going to discuss further. Then you look at the kinetic criteria. The kinetic criteria is the mobility. So the tissue can be mobile, which can be free in the cases of PVD, and which can be limited in cases of retinal detachment and choroidal detachment. So how do you differentiate? So let's start looking at individual pathology, individual key findings. One is point-like echoes. So if you see these point-like echoes, which could be vitreous cells, hemorrhages, or asteroid hallucis. So if they have a low to mid reflectivity, then probably you're looking at vitreous cells. If you have a medium reflectivity, then you're looking at a patient of hemorrhage. And if you have have high reflectivity and at the same time has an equilucent gap, then probably this is a patient of asteroid hallucis. Apart from that, you never make the diagnosis just looking at the ultrasound. You always give a differential diagnosis, and then you correlate the differential diagnosis with the clinical picture that patient has. So if a patient who is diabetic, most likely the patient is going to have a vitreous hemorrhage rather than vitreous cells. A patient who is having a red eye, when you see this kind of picture, probably these are nothing but vitreous cells. Again, based on the ultrasound B scan, you can differentiate between rhegmatogenous, fractional, and serous retinal detachment. It is based on the attachment. So, rhegmatous retinal detachment will have, will show after movements, but will be attached to the disc where the retina is attached. While traction retinal detachment can happen any part of the retina. Again, this is going to be associated with diabetic retinopathy, and they will little to no after movements. While in case of serous detachment, look for any kind of mass in the retina. So what you see over here is a serous detachment. This is a high reflectile membrane which have a high acoustic impedance, and you see an abnormal, mass lesion. So probably this is a serous detachment because of some pathology in the corridor of the retina. So when you see another kind of dome-shaped retinal detachment, which have 100% reflectivity of the retina, but thickness is compared to be thin, probably it's a retinostasis. You can do an ultrasound and you see this folding of the retina, just like this in this patient. You are looking at a giant retinal tear. You see this, thick stalk with a, pyramidal shape of attachment over the disc. It is a patient of persistent hyperplastic primary vitreous, and you can also see this. This is a detachment, and what you see is an open break with and shadowing. Probably this is where the scleral buckle is being placed in this patient. So ultrasound B scan is as an exam for you is in cases how to differentiate between choroidal hemangioma and choroidal melanoma. So choroidal melanoma has been described as mushroom-shaped lesions, which have a regular internal structure. So you see this has a regular internal structure, and has a because the acoustic impedance which developed over here is dipping slowly. So you see, and because of the homogeneous structure, this impedance is going down, and this is what is known as delta sign. So this is large angle kappa sign, which is described in choroidal melanoma. Apart from that, there is another thing which has been described for choroidal melanoma is choroidal excavation. What you see is that this is the pathology in the retina with an excavation of the choroid on B scan. This is choroidal excavation sign. So you need to know choroidal excavation, large angle kappa, and mushroom shaped appearance. While an choroidal hemangioma has heterogeneous, so heterogeneous you will see irregular decrease in the when the ultrasound is passing through any kind of tumor, it is going to lose its intensity with time. So because the hemangioma has a heterogeneous structure, so it's going to again have a decrease in the A scan intensity, but this is going to be heterogeneous. So another lesion on ultrasound B scan, you see an irregular high internal reflectivity and with posterior shadowing. Probably this is a calcium deposits, and you are looking at a patient of an exophytic kind of endophytic kind of retinal blastoma. When it is associated with a retinal detachment, as you see over here, you are looking at a patient of an exophytic variant of retinal blastoma. Intraocular foreign body based on the material they are made up of. If you have a metallic foreign body, this is going to have you can visualize this in ultrasonography, but then this is going to have a high acoustic impedance with after shadowing. So this is going to appear very bright and will have an after shadowing. So this can help you to identify intraocular foreign body. What you see over here is posterior dislocated lens into the vitreous. Just wait, I'm going to discuss another case with you. And then if you see these reverberating shadows, you see 1, 2, 3, 4, 5, 6, these are reverberating shadows because of the IOL. So if you see this image, this is because of the IOL. So look at this image and look at this image. So you see this is an invert ring. This is the diamond which is inverted signet sign. So this is probably and with an associated retinal detachment. You don't see retinal detachment over here. You see retinal detachment over here. So this is a patient of a neurocystic psychosis, while this is just a nucleus drop, or sorry, lens drop. In this patient, what you see is this hyperreflective a tissue which has a high acoustic impedance with a hyperreflective structure. It has a high reflectance, and you see a post-acoustic shadowing. So you see this abnormal lesions, which is very white, which is having high acoustic impedance on ultrasound B scan. So probably you are looking at a choroidal osteoma. Again, if you see this fluid around the sclera or behind the sclera, probably you're looking at a patient of posterior scleritis with associated thickening of the sclera. When there has been described the tram track sign, when you see in a patient of red eye, and the vitreous has those membranes, probably you're looking at a patient of endophthalmitis, and the sign which is known as this sign of fluid which is here and here is known as T sign, which is described in endophthalmitis. To summarize, ultrasound B scan is a very informative device in patients where we are not able to visualize the fundus of the patient. It can help you to cleanse the diagnosis of diseases like retinoblastoma, because you can visualize calcification with the help of B scan. It can also help you to guide the surgery. Like in the patient, when you're planning to do an PPV, you do an B scan in this patient, do an axial scan, you will know that the axial length is around 30 or 30 mm. So now the usual armamentarium that you have for PPV, you need an different kind of longer forceps and longer instrumentation for those kind of eyes. So it gives you a 3D analysis of the ocular trauma and tumor evaluation, 3D analysis of the ocular trauma and tumor evaluation. So ColorStud, which has been described in choroidal melanoma, is because of the 3D or the depth perception that can be done with the help of an ultrasound B scan. So one thing that needs to be remembered is B scan is an operator dependent. It needs a learning curve, and it is less detailed than OCT MRI. UHG B scan excels when the eye cannot be seen. When UHG B scan excels when eye cannot be seen to quantify finding, but it gives you a causal detail. So it's an excellent device when you are not able to see the fundus, or you're not able to visualize the structures of the retina because of some problem. Maybe the patient may be having as simple pathology as a total intumescent white catheter. Thank you.
Thank you so much, sir, for this extensively covered lecture. I know this was quite challenging because of how vast this topic is, and you've managed to cover all the key points in this short time. So I think all the questions that we have, I was just going through them, and you've addressed most of them. So there isn't much left for us to ask separately. So thank you again for covering everything so extensively. And for the rest of our viewers, our next class would be on 30th of May, which would be sort of a master class on how to optimize your score by Dr. Prafula Kumar Maharana. So we'll see you then. Thank you so much again, sir.
Thank you. Thanks a lot.